Good evening, good afternoon, and good morning. This is the 2077th day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. Professor Partha Chakraborty. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathy lovers, students, and doctors, and we have 3 sessions every day. The first session of the day is already over in Hindi from 7:30 to 8:30. From 8:30 to 9:30, we have the international session in English, and from 9:30 to 10:30, we have a local language session in Malayalam. We are uploading the videos of the same on the very next day itself, so that those who miss the session can watch it again. You can subscribe the same without paying any money. You can share it with anyone who loves homeopathy. The purpose of the forum is to take homeopathy to every home around the world. And we have so far uploaded more than 3,600 videos. And let me come to today's guest. As you all know, it is none other than Professor Dr. Partha Chakraborty. And sir is working in Malaysia, actually from India, and has presented so many brilliant sessions in our forum. Not only here, he is an international as well as national presenter, and people around the world is looking at him for his sessions. And sir has completed MD in homeopathy, B.Sc, FSS, FF homeopathy, and so far has treated more than 2 lakh cases in his own clinic, and has experience of more than 2,000 clinical records maintaining in his clinic also. And he has special interest in brain cancer, brain tumor, cancer, allergic disorders, skin disorders, endocrinology disorders, and particularly taken classes on thyroid disorders as well as brain tumor. That's one of the most important aspects of sir. And working as a postgraduate professor, international PG course of classical homeopathy, Loyola University, Bolivia, in 2000 from 2024. A present associated with Department of Homeopathy, Lincoln University College, Malaysia, and engage in online as well as part-time teaching to students, and occasional visit assistant professor at B Homeopathic Medical College in 2000 to 2007, and Doctor of Medicine, MD Homeopathy, BRA, Bihar University. And Dr. Sir will be talking about a very important subject, that is in female infertility, causes, management with case illustration. We proudly welcome sir to this session. Welcome, sir. Yeah. Please unmute, sir.
Yeah. So, Dr. Dhanesh, am I audible?
Yes, sir.
Okay. Very good evening, everybody. Still, I was very busy for the last 1 year, so I could not take many sessions. I am very thankful to Dr. Dhanesh and IFPH especially for inviting me once again over here. I feel, a lot of excitement within myself when I come in this session. So I'll just start my session because time is very limited. Yeah, I think you can see it,
Yes,
Dr. Dhanesh? Okay.
basically, fine.
So, as Dr. Dhanesh actually introduced me that I am very interested about these neurological cases, and yes, that's 100% true. I'm very interested in neurological cases. I've been getting lots of neurological cases, and with God's grace, I've been successful in many cases. This is another subject which I've been very interested, and I've been treating many cases of infertility since I began my practice in 1996. I remember the first case of infertility, female infertility. Today we will be talking about female infertility. Infertility can be divided in 2 parts. One is female infertility, and another is male infertility. So today our discussion will be regarding female infertility. And I remember the first case that I treated in my career was, I think, around 27, 28 years back. The first case, that boy is now around 28, 29 years old. And the latest case that I saw the latest birth, that case I will show today, that baby is around 1 year. And after that, many women have conceived with homeopathic treatment. So this is a vast subject. Female infertility is a vast subject. Many things has to be known. Before we go into female infertility, we have to know the anatomical structure of the reproductive system. We have to have a little bit of knowledge about the physiology, how do the hormones act, and then only we can actually get into these problems, and we can try to solve these cases. No doubt, these are very difficult cases, very demanding cases, because when a patient comes to us with infertility, before coming to us, they go to many doctors, gynecologists, obstetricians, surgeons, and after they fail there, they come to us with a lot of hope. And the problem is that why I told that it's a very demanding thing, that the patients, they are not willing to spare a lot of time for us. So we have to deliver results within a very short time. So that's the biggest challenge in cases of female infertility. Even after the first prescription, when the patient comes to you, say for example, after 1 month back, 1 month after, the first question that she will ask you, or the couple will ask you, Doctor, I have not conceived. So these are very demanding cases. It needs prudence in treating these cases. It needs a lot of knowledge in treating these cases. So I am trying to share my brief experience with all of you, the learned guests over here. So before I start the presentation, I told you that we have to know the different parts of the reproductive system. Let us go through it once again. We all know these things. So this is a longitudinal section of the uterus and the ovaries. You can know that this is the main body of the uterus. This is a fallopian tube. These are the ovaries. This is the ovarian ligament. And this is a cervix and this is a vagina. Now, after intercourse, what happens? The sperm, the lot of sperms are ejaculated, and these sperms start swimming like this. There's a very interesting thing over here to know that sperms actually they swim upward. They swim against the tide. They go upward like this. And one sperm is actually lucky to fertilize the ovum. Only one ovum is released. Just remember, one ovum is released from this ovary. It comes into the fallopian tube, and out of millions of sperms that is ejaculated, only one sperm will be able to fertilize that egg and form the zygote over here in the fallopian tube. And then the normal physiology is that the zygote will travel like this and embed in the uterus. This is the myometrium, endometrium or myometrium, endometrium, not myometrium, endometrium. And the zygote settles over there. That is the normal physiology of reproduction. Very, very short. I've told it in a very short way. It's not so easy. It's a complex mechanism involving a lot of uh, hormones, muscular structures, neurological structures. So this is the way this is acting. Now, what is before we come to infertility, we have to know what is female fertility. That very simple definition of female fertility is it's an ability to conceive a child through sexual intercourse. This is a very simple definition: ability to conceive a child through sexual intercourse. Then, what is female infertility? Female infertility is it's the inability to conceive a child after 12 months of regular unprotected intercourse. Each and every word in this definition is very important, because why I'm telling you about this definition is that it can happen that after 2 or 3 months of marriage, one couple comes to you and tell you, the doctor, we are not being able to have child. So that is not a case of infertility. They have to spend at least 12 months, 1 year of regular unprotected intercourse. If they are using oral contraceptive pills or any other contraceptive measures, that won't come under infertility definition. So this is very important that a couple should try for 12 months of regular unprotected sex, and after that, if they are unable to have a child, and if there is a problem with the female, definitely, then it can be termed as a female infertility case. In some cases, what happens? The problem lies with the male also. The female doesn't have any problem, but the male might be having some problems like some problem with the sperm quality, sperm quantity. Even I've seen cases where the male has got no sperm. That's called azoospermia. In fact, there's a very interesting thing about azoospermia. There is a common notion that azoospermia cannot be treated. But I have myself treated in my life at least 3 or 4 cases of azoospermia where the male, after treatment, the male has been able to produce sperm, and that also normal morphological sperm, and up to a certain more than 50% in a month. So this is the thing. Now, if you ask about statistics, about 10 to 13% of women are suffering from infertility. 10 to 13% of females are suffering from infertility. I told you already how common is this problem. This is not a very uncommon problem. This is quite a common problem that around 10 to 13% of women suffer from infertility. Now, what is the criteria in diagnosing female infertility? This is very important. The definition itself told that 12 months of regular unprotected intercourse. After that, if the couple is unable to have a child, when the male factor is not there, when the male is having normal sperm morphologically and quantitatively, then we can define that case as a case of infertility. Now, nowadays, what we are seeing, at least in India, we can see that because the girls, our daughters, girls, they are studying, they are working, and they are having late marriage. They are having late marriage. Most of the girls are marrying after 27, after 30, after 32. So they are conceiving after 30s. So when a woman crosses 35 years of age, then this infertility definition will be slightly different. The definition will be 6 months of unprotected regular intercourse. In that case, if they are unable to produce a child, then it can be treated as a case of infertility. But if if the woman, if the woman is below 35 years, then that definition will stand. So this thing you please remember. So what are the types of infertility? There are two types of primarily. Initially, I told you male and female infertility. Today we are talking about female infertility. So there are two types of infertility. One is primary infertility, another is secondary infertility. Very interesting thing. Now, what is primary infertility? Primary means that the couple or the woman has never conceived any child. So the definition of primary infertility in females goes like this: inability to conceive after 1 year of regular unprotected intercourse. Inability to conceive after 1 year of regular unprotected intercourse, provided the woman is below 35 years, and if she is 35 years and above, then the criteria will be 6 months. That is primary infertility. She has never conceived. Secondary infertility in females. What is secondary infertility? Inability to conceive after previous successful pregnancy giving birth. This giving birth is very important. It might happen that a case will come to you where the female has, I've seen many cases like this. The female will be, having 2 or 3 abortions after marriage, and now they are again trying. So that cannot be considered as secondary infertility because she hasn't given birth to a child. She has aborted. That can be naturally aborted. There can be some circumstances where she had to be medically aborted. So that in that case, the definition will be the case will be diagnosed as primary infertility. So this definition should be very clear that secondary infertility, in case of secondary infertility, the woman must have given birth to a child. Even it can happen like this, that a woman has got divorced and after the divorce she has married somebody else. Now she is not being able to conceive. But from her first marriage, she is having a child. So in this case also, she is suffering from secondary infertility. What are the presenting symptoms in infertility cases? Very simple. The main presenting symptom is inability to conceive. The couple will come to you. They will tell you, doctor, We are married for 1 year, 2 year, 3 year, 4 year, but we are not being able to have a child. We have been trying for the last 2 years. We have been trying for the last 3 years, but unfortunately, we didn't have any child. Even it can happen. These things I'm telling from my own experience. Even it can happen that they have gone through IVF also. They have gone to allopathic doctors. They have tried for IVF, but then also they have failed. These cases also come to us very often. And associated with this inability to conceive, there might be some other problems. That means there might be some physical problems. Physical problems might include, some uterine problem, some ovarian problem, because ovary, uterus, fallopian tube, these are all essential part of the reproductive system. So if there is any medical disease involving any of this part, then also the woman might be suffering from infertility. And another problem is very important, which is actually very dominant in our country, that is psychiatric problems. In our country, especially in the rural areas, I have seen that sometimes this infertility is treated as a stigma. When a woman is unable to conceive, the other village woman, they try to, or the family members, they try to put a blame on the lady, poor lady, that you are having some problems, you are not being able to become a mother. And that actually has got some reciprocal psychiatric effect on the lady, on the woman. So normally the presenting symptom will be the couple will come to you, tell you that we are not being able to have a child. Secondary, they might be having some problems with the organs which are involved in the reproductive system, some medical disease like tuberculosis of the fallopian tube, anything it might happen, hormonal problems, and last but not the least is the mental symptoms. And I've seen that the biggest challenge is the psychosocial aspect faced by the mother. So while you are trying to treat these cases, you have to assure the woman, you have to tell the husband that you have to support the lady in cases of these adverse comments, adverse any sort of behavior from the family members, because this is simply a disease. She has got nothing to do with it. She's unfortunately suffering from a disease and she is not being able to conceive. So you have to not only treat, but you have to counsel that couple also. That is very important in infertility cases I've seen. And that makes these cases unique from the other neurological cases, this counseling portion. So I told you the society looks upon the poor woman with suspicion, blames her for not conceiving. And infertility is the biggest stigma faced by any woman. A lot of depression is created. Now, what are the consequences faced by the patient? The patient means the woman over here. Increased stress, anxiety, and depression. As the days are going on, as the months are going on, as she is being menstruating every month, she is becoming low and low and low in her self-esteem. Her self-esteem becomes low and low and low. It's touching the lowest ebb. So she starts suffering from anxiety. She starts suffering from depression, and she loses her self-esteem. And sometimes at a point of time, she'll be reproaching herself. She'll be actually blaming herself that I am responsible. I'm not being able to conceive. And what happens? That causes some discord between the husband and the wife. And sometimes infertility is associated with eating disorders. Psychiatric disorders are associated with bulimia. There's a term called bulimia. So infertility cases I've seen, they are suffering from bulimia also, resulting in obesity. And other addictions also might happen. Sorry. The causes of infertility. This is very important. Why causes are important? Because once we are being able to know the cause, our treatment, our management will be more easy. Now, causes can be divided broadly into four portions. There are 4 points where we can divide the cause. First is the ovulation problem. The ovulation means the release of the ovum from the ovary. The ovary is responsible for the release of the egg. One thing I'll just tell you, these are all, just what I'll say. recapitulation of the old studies that we have done. That when a girl is when a girl child is born, she is born with the total reserves of eggs, just like our neurons. When a child is born, the total number of neurons that she gets or he gets at birth, that is the total number of neurons. Neurons are never regenerated. Similarly, when a girl child is born, the total number of eggs that is already there in the ovary. When she grows up, one after another, this follicle matures, and this follicle releases the egg into the fallopian tube. So this when the ovum is released from the follicle, that process is known as the ovulation. That is known as ovulation, which is occurring just around 14 to 15 days prior to menstruation. So there might be some problem with the ovulation. There might be structural problems. Structural problems means if in the uterus, you remember that picture which I showed in the beginning, if in the uterus there is a big fibroid, there is a big cyst. If in the fallopian tube there is a inflammation, there's an infection which is causing adhesion of the fallopian tube, causing obstruction, or the growth might be causing obstruction in free flow of the sperm and the ovum. So these structural problems, even some extra growth, there's some tumor in the outer part of the ovary or the fallopian tube. They also cause some compression effect on the fallopian tube or the uterus, resulting in infertility. So structural problems also can cause. I've seen cases like huge fibroid. That is the main responsible factor for infertility. Endometriosis, that is main factor for this infertility. The other factor which is very important is hormone imbalances. Because everything is totally, I told you that it's a complex procedure and hormones play a major role in infertility. What are the hormones? Mainly FSH, LH, GnRH, prolactin, then progesterone, estrogen. These hormones, they have got their own individual responsibility. They have got their own individual responsibility in assisting in this process. So, if there is a problem with any of the hormones, then that process will be interrupted. Other factors, that means other medical diseases, can also cause this infertility. Ovulation problems, just to get some precise information on ovulation, what are the ovulation problems? The most common ovulation problem that we are seeing nowadays is the PCOS. Some say it as PCOD, some say it as PCOS, that is polycystic ovarian syndrome. This is actually a totally hormonal imbalance, problem with hormonal imbalance. Sometimes there is some insulin resistance which is causing polycystic ovarian syndrome. Now, what is polycystic ovarian syndrome? Just let me tell you briefly that when a follicle matures in the ovary, and after certain time, with the help of the luteinizing hormone, this follicle, when it gets matured, after certain time, with the help of FSH, that follicle actually matures. And after a certain time, with the help of LH, luteinizing hormone, that follicle bursts. And after getting burst, that egg is released. Okay. Now, this follicle, if it doesn't mature properly due to any reason, and it remains in the follicular form, that is actually causes that becomes cyst-like that have got cyst-like appearance. That is known as polycystic ovarian syndrome. That can cause infertility. That is the most commonest hormonal problem which is causing infertility. Then primary ovarian insufficiency or poor ovarian response. That means the ovary might be diseased. What happens, sometimes the lady is around 30 years, 35 years, but the ovary function is not proper due to any reason, due to any medical reason, due to any hormonal reason. The eggs quality is not good. The number of eggs is not sufficient. This thing we find in case of aged women. When I remember a case came to me around 6 or 7 years back. That lady was around 38 years old. Now, her main problem was a poor ovarian response. She went for treatment. She went for 2 IVFs. Then also she could not conceive. But after prolonged homeopathy treatment, she considered, and her daughter is now around 6 years. If I get some time, I will tell about the case some other day. That's a very interesting case. Now this poor, she had got a poor AMH, anti-Mullerian hormone, that is actually indicating towards poor ovarian response. Hypothalamic dysfunction. Hypothalamus is actually responsible for release of gonadotropins. Gonadotropins are in their term, they are actually releasing FSH and LH from the pituitary. They are actually helping in release of FSH and LH from the pituitary, anterior pituitary. So if hypothalamic dysfunction is there, so GnRH will not be produced and FSH and LH will be hampered, and irregular or absent menses. This is ovulation problem. Second is structural problem. I have told you that fallopian tube damage may be there, blockage may be there, uterine problems like cysts may be there. Endometriosis is a very painful condition. It can be, it can cause infertility, and pelvic adhesions due to any disease, any inflammation, any infection. There might be some adhesions causing obstruction in the free flow of the sperm on the egg. These are all structural problems. Hormone imbalances, I already discussed disruption in production of regulation of hormones. Any of the hormone, estrogen, progesterone, FSH, LH, GnRH, even prolactin. If there is any excess or under production of the hormones, it can cause infertility. High prolactin level, I have mentioned it differently, separately, because prolactin is another hormone which is released from the pituitary gland. And this prolactin is responsible for the milk production. But if there is a high prolactin level in that woman, that can cause a retrospective, that can actually disrupt the ovulation process, as a result of which the lady might be suffering from infertility. And thyroid problems are very, very common. If the thyroid stimulating hormone is more or less, in hypothyroidism and hypothyroidism, in both cases, we can find this infertility cases. Age Age is a factor. As the woman grows older, there is little chance, because the ovarian response is poor. The ovary gets burdened. The reserve of the eggs becomes less. The quality of the eggs becomes bad. So age is a major factor. Lifestyle factors. Nowadays, the women after office hours, they're going to the pubs. They're not taking proper rest. This is also another factor. Medical conditions like diabetes mellitus, hypothyroidism, thyrotoxicosis, any cancer, this can cause infertility problems. Genetic or chromosomal disorder. This is also very important. When we were students, we remember that we were taught about a condition called blighted ovum. I have seen one case, one lady, I remember she was a walking lady. And after many, 1 or 2 years of trial, she came to me. And after treatment, she conceived. But unfortunately, in the third month, she aborted. She aborted a large amount of, there's a huge amount of clot came on. That was actually the zygote which was growing into an embryo that actually came out, because it was a genetic. She was having a chromosomal problem, something like that, and she could never conceive, unfortunately. So this can also come into our practice. And sexually transmitted diseases. There are a lot of sexually transmitted diseases which can cause any sort of medical problems like addictions or any infections or inflammations, that also can cause infertility. Now, so far I have been I was telling you about a brief uh, study about the fertility things. This is a very big thing, but it was a short introduction. I'll come to case study. I'll be presenting. I've got a lot of cases in my life, but here today I'll be discussing about 2 cases, and in some next session I'll be talking about some other cases also. So in managing female infertility cases homeopathically, we have to take mostly the physical symptoms first, because when a patient comes, I always have told my students that when a patient comes, don't try to take the mental symptoms, because the patient will not be able to share with you their this mental problems. So try to go through the physical symptoms first, and then when you gain the confidence of the patient, come to the mental symptoms. So physical symptoms should be asked more specifically about the reproductive system, like her menarche, like her menstrual pattern, whether it is regular or irregular, whether she is having any. We have to go through the ultrasonography or any scan, CT scan, whether she's having any medical problems, whether she's having diabetes, whether she's having thyroid problems. So every symptoms we have to take note and we have to try to diagnose whether she is having any blockage in these cases. And then we have to, after this detailed study, then we have to come to the mental symptoms. Just yesterday, one case came to me, I remember. She came to me primarily with her menstrual problem. That couple came to me, that doctor, I'm having irregular menstruation. That means sometimes I'm having 2 times in a month, sometimes 2 months are gone, I'm not having any period. Sometimes in 1 month, I'm having one period, but it's a very prolonged one. So it's a totally, irregular period. There's no regulation. And immediately I asked her, she's around, I think, 28 or 29 years. I asked her whether you're having a child. She told me. She told that we have been trying. I told her that this is the problem. This menstruation has to be regulated. And once that can be regulated, we can try that you conceive. So they came with the menstrual problem, but the actual problem was not only the menstrual problem, that is also causing primary infertility in that case also. So and in that case, I remember when I was taking the case, after some time, this is a very common question I'm asking the patients, that in a family, how many persons you are staying in a family? If they tell that we are staying in a joint family, then I ask, what are your how is the relation with your husband? How is the relation with your mother-in-law? How is the relation with your sister-in-law? Because these things, these social factors, they are not to be neglected. These are very important. They are causing constant stress upon the woman, which which is causing a retrospective, disbalance in the hormonal system, which is causing psychiatric problems. So these things has to be very cleverly taken. These points are to be very cleverly taken. You have to take the patient into your confidence, and then you can take these things. This is the first case. The patient came to me. Remember the name of the place? It's called Purulia. It's a very rural area. She came to me, 32 years. No, sorry. This case is not from Purulia. This case was far from my place. She was staying far from my place. 32 years. She is a working lady, working in and I think in an IT company. Date of first visit was 9th of October 2024. Married for 6 years. So she was married at around 26 years age and trying for a baby for the last couple of years, I think. Yeah, for the last couple of years. But she has never conceived. So from the very beginning, very definition of primary infertility, we can diagnose that this is a case of primary infertility. A couple who has been trying for the last 24 months. The criteria is 12 months. They have been trying for the last 24 months, regular unprotected sex intercourse, but she has not been able to conceive a child. And her husband was fine, okay. He didn't have any problem with the sperm, and there has been no history of intake of OCTs. That means oral contraceptive pills. Nowadays, a lot of women are taking oral contraceptive pills, so this history is also to be taken. Menstrual history, menarche, that means the onset of period was in 14 years, quite common. It's okay in tropical countries. Regular menstrual period, but amount was less. Duration of each period around 3 days. Pain in abdomen on first day. This is also very important. You have to ask about dysmenorrhea. And she told that first day I'm having some. So she was having some sort of congestive dysmenorrhea. Pain on the first day normally is defined as congestive dysmenorrhea, and she needs painkillers. She sometimes misses office. No history of premenstrual tension or mood swing. This is also very important. This premenstrual syndrome, this premenstrual tension, mood swing, headache, pain in the breasts, a bloated feeling, these symptoms are also very important. You have to take note of this thing. In fact, these premenstrual symptoms actually, alert a woman that you might be having period in a couple of days. And last period was on 27th of September. Duration was 2 days only. Duration was 2 days only. So it might happen, duration is less, the amount is flow is less, That means it might happen then that the endometrium is not, very thick in this lady. Other symptoms, uh, in past history, she had got a history of childhood tonsillitis, father's history, type 2 diabetes mellitus, very important. Because if she suffers from diabetes mellitus also genetically, then also it can cause hindrance. Mother's history, hypertension, stool, usually constipation, and she needs some fibrous foods. Urine, there was no abnormality detected. Urine is normal. Perspiration, moderate. Appetite, uh, it was nothing abnormal, normal. The normal food she was taking. Other symptoms, she's having profuse leukorrhea, and the leukorrhea was going for the whole month. This cervical discharge is also very important and an important factor in cases of infertility because they cause a hindrance in the free flow of the sperm towards the fallopian tube. So this profuse leukorrhea, it can happen due to hormonal imbalance. It can happen due to poor hygiene by the woman, whereby there are some local infections in the uterus and cervix, resulting in a lot of leukorrhea or cervical discharge, and that can cause infertility. Another symptom that the lady shared with me that doctor, always I'm tired, I'm fatigued. Even during working hours, in the office hours, I feel sleepy, I'm yawning, I'm very, very tired. And she emphasized on this problem very much. She was a moderately built person, fair lady, moderately built person. Now, after getting all these things, now I told her that I'll be asking you some very personal questions. Please cooperate with me. And then I asked you, what are your stress factors? If you are asked to identify your stress factor, what is your stress factor? She told that I'm the only daughter, only child of my parents. Her parents actually stay in my city, and she stays long away, around 2,000 kilometers from my place. She's working in another place. India is a big country, So she told me that always I'm worrying about my parents. They have become old. My father is suffering from diabetes. Mother is suffering from hypertension. So I'm always having some tension that whether they are okay or not. If they fail ill, I have to immediately rush from that place. So this is a big stress. Another, I told you that she was working in an IT company, and normally IT companies in India, they are putting a lot of pressure. We are all knowing this thing. So this stress about parents' health as well as office work stress, and she had to commute a long distance from her home to the office. She had to commute a long distance. So all put together, it was a stressful situation for the lady and recent depression or utter sadness because she was not being able to conceive. I told you that with each passing menstrual period, the lady was actually dropping low and low and low. So that is a big problem. But another thing, when I asked if you're having any fear or like that, sometimes you have to ask some specific question, direct questions. She told, yes, I'm having some fear of downward motion. Downward motion. Whenever she's traveling some days the road is inclined downwards, she's not feeling comfortable. So any sort of downward motion is not comfortable for her. She rather fears it. Pathological investigation, serum prolactin 27 point normal. 24 is a normal, 27 is not a very big factor. TSH levels are normal. Salpingography was done just to see whether the tubes are patent or not. Fallopian tubes are patent, so there shouldn't be any problem for the sperm to get inside the fallopian tube. Husband's semen was normal. Normal morphology was 78%. Mortality was 60%. More than 50% mortality is fine. Now finding the remedy, that is the most difficult task for us. I took all the symptoms. I went for a total repertorization. Another thing, very interesting thing, just note here. Here, the rubric in the repertory, if you open the repertory, you won't find infertility. There is no rubric called infertility. Just note it. You will find the rubric for infertility in repertory is sterility. So I opened female genitalia sterility. That's the main thing. Kent always told that take the broad the main rubric, the broad rubric, then you come to sub-rubric. So sterility was taken. Sterility with leukorrhea was taken because leukorrhea was a very big factor. Leukorrhea itself was a general rubric I have taken. Weakness. This physical concomitant was very important. And mind symptoms, anxiety, health about relatives. There is no rubric in the census repertory called anxiety about parents because that is quite common. Anxiety about parents is quite common. So I took the rubric anxiety about relatives, fear, fear about the health of loved person. That is another, another similar rubric that I've taken, and fear of downward motion. This is a rubric I've taken because this is a symptom I've taken because this has got nothing to do with the directly with the infertility, but definitely it's an important fear. This uncommon, unusual things should attract your attention. So I went for this total repertorization, and you can see that these are the drugs coming: mercurius, copulus, ammon carb, arsenic, calcarea, natrum carb, phosphorus, borax. They are all coming. Now I was not very satisfied with this thing, so I tried to you know uh, shorten the repertorization. I took some symptoms which are actually can called as eliminating symptoms. That means without these symptoms, this case cannot stand. So I took the physical symptoms like sterility, leukorrhea, and I took only one mental symptom. That is what is very uncommon for this case. Because fear, anxiety about my parents, about my daughters, about my son, quite common. But fear of downward motion is a very peculiar of that particular individual. Everybody is not afraid of downward motion. So I took this rubric and the other physical rubrics I took, and you can see the total, repertorization has been changed. Now the drug is coming borax, creosote, natrum carb, calcarea, silicea, aletris farinosa, very good drug, aletris farinosa. This weakness, fatigue, very good drug. And I selected borax because borax was covering all the symptoms. Borax is the only drug which is covering all the symptoms. Sorry,
Sir,
sorry for the.
sir, before, please show the prescription once again.
Okay.
Yes.
Okay. So you can go through Kent's Mathematica, where you will find a very nice description about borax, why borax is important for infertility problem. I'm not taking much time. Consultation was then the next after borax, the next consultation was in December. The first was in September, sorry, October, and then December. She got her periods in November. Dysmenorrhea much less, flow was better, feeling better in all aspects. Fatigue was less, but she hasn't been able to conceive. I told you that these are very demanding cases. After one period, they will ask you, Doctor, have not been able to conceive. So everything was better, only the main thing was not obtained. Though she was feeling better physically, but she was not mentally better because she was always thinking about her pregnancy, anxiety regarding pregnancy, and that anxiety was growing and growing. And that anxiety was maximum when she was alone. When she was working from her home, sometimes she was having her anxiety, maximum anxiety, and she was feeling that she was a failure. So you find that the anxiety now is turning towards some desperation, some depression. This change of these mental symptoms, the intensity of the mental symptoms, this is also important. So you have to change your rubrics also. So in this case, the psychosocial aspect is very important. The psychic state of the female might be the main hindrance to conception. So the mental symptoms, the mental concomitants were slightly taken, the depression were taken, and the repartition of the seat was like this. Mainly over here, you can find that I've added more of mental symptoms: mind anxiety, fear of failure, despair, sadness. There is no rubric for depression. The rubric for depression is sadness. Now you find phosphorus is coming. Phosphorus is another very good drug. Phosphorus is coming. Okay, I change. Prescription on 19th of December, phosphorus 200. Husband was given testosterone 6. Now, the third consultation was in February, 28th of February. Now they went for this. The lady missed her period after January. In February, they went for the HCG test, the break color test, and you see they've done a double break color test on consecutive days, and both were positive. This C is for control, and this is for the test. Both should be red. And they went for another sonography in the 6th week. In March, the sonography report shows single live intrauterine embryo of 6 weeks, 4 days, but with irregular sac margins. This thing you can note, irregular sac margins. That means the embryo was not fully developed. Now I asked her that you go for another, sonography after 2 or 3 weeks. They went for another sonography in the 9th week. That means on date 26th of March. Now you can see that single live intrauterine embryo of 9 weeks. That means the embryo age is corresponding with the last menstrual period, and the sac is fine. There is no irregular margin. So the live fetus is okay, fine. And they went for another modern test, the blood test, where the beta HCG is measured. These are the very confirmatory tests. When the beta HCG is high, then you can be very sure that the lady has conceived. Beta HCG normally in non-pregnant females are 5.3, but she has got more than 3,000. So she was absolutely, you know, uh, pregnant. She has got pregnant. Now after that, they went for some other gynecologist for their child, and they have got their child. I heard, because they are staying long away from my place, long distance from my place. They have got their child. I heard from their relatives. So this was the first case of today. The second case will be like this. Time is very short. Date of first visit 20 years. Very young female, 20 years. Date of first visit 2024, 1st of February. Married for 2 years, trying for a baby, never conceived. So another case of primary infertility. And she has got a short history of intake of OCPs, but now she is not taking OCPs. Gynecological history, menarche, 15 years of age. She had irregular menstrual period, 2 to 3 months amenorrhea. She took some medicines. Duration of each period 5 days. Clotting was there. She has got congestive dysmenorrhea, pain in the abdomen and back on the first and second day, and white discharge, that is leukorrhea, before and after menses. The last period was on 5th of January. Other symptoms: past history, nothing abnormality detected. Family history, father's history, hypertension. Mother history, nothing abnormal. Morphology, moderately built lady. Young lady, very young lady, I remember. Stool was regular urine. These are very normal things. Dyspepsia, that means after eating foods, she had got some sort of GERD. Mouth was sour. Acid reflux was there. Now, mind symptoms, when I was asking the patient, I was trying to get symptoms from the patient. The patient was less responsive. And the husband was actually, telling all the symptoms. The husband is working in the police department. So he is slightly dominating over the wife, and the wife belongs to the rural area. So she was less responsive. She was, in fact, less cooperative also. But the symptom that I got from her husband, that she was having a tendency of easy weeping, and she has got a fear, apprehensive fear, because her husband was working in my city where I am staying. He's working in the police department, and she was staying in a village area. She was staying with her in-laws only, father-in-law, mother-in-law. She was alone over there. So she was always having a fear, apprehension, some fear she was having. These tests were advised. Now this repartition sheet is like this, quickly repartized. Mind weeping, mind 4-second feeling, mind fear of being alone, and then irregular menses. So pulsatile was coming and pulsatile was prescribed. Husband was not given any medicine because husband was fine, 200. Date of second visit, 29th of February 2024. Last period was 23rd of February. Flow was profuse and clotted. D10 USG. USG told that mildly thickened endometrium, no conception was there, and they went for this AC test. I don't know why did they go there. You see that the control was red, but the test is not red. This is a case of infertility. That is, she has not conceived. Pulsatile was repeated as the patient was absent. Third visit was in April. The last period was in 4th of April. 5 days. It was delayed. There was dysmenorrhea, cramps in the back. No new symptoms were added. They were obtained. Now, these are the blood tests. Prolactin level was normal. Thyroid level was normal. And these tests were all, rubella was slightly high. Toxoplasma and rubella IgG. This is called TORS profile. This was slightly high. Testosterone was normal. Almost everything was normal. AMH is normal. This AMH. Sonography, mildly thickened endometrium, and there are some small cysts, sub-centimeter cysts, PCOS features. Husband semen, normal morphology, 80%. Motility is 84%. Now, repartition was done. Pulsatile was coming again, once again. Now, pulsatile 200 along with viburnum 3x was given just to reduce the cramping, the pains. Viburnum 3x. And viburnum 3x was given, there was another reason for that. If you open the Boric, if you remember, Boric has written that viburnum not only prevents the cramps, but viburnum also helps in preventing any sort of miscarriage. Any sort of miscarriage also viburnum prevents. So that was another reason that viburnum in very low potency in physiological dose was given to that lady. Fourth visit was in June, 7th of June. These are the symptoms. And the last reporting was in July. When on 12th of July, the husband reported the last period was on 4th of June. After that, she's having amenorrhea and she went for this test. This is brake color test. And now you see it's positive. Both the lines are red. The control is red. It is always red. And the test is also red. So she has conceived. Now to confirm, we have to go for a sonography. This was a confirmatory sonography. You see, 14th of this August, it was reported that she's having a single intrauterine gestational sac, 6 weeks, 1 day. That means the age of the zygote or the embryo is corresponding with the last menstrual period. So this was another successful case of homeopathic infertility treated by homeopathy, and this was the another confirmatory USG was done. The same report was coming that she's having a live intrauterine embryo. This was the child. Now he is almost 1 year old. So these were the two cases for today. Later on, also I can just go on with this series. Okay, thank you, Dr. Dhanesh. I'm on time. 5 minutes before.
Yes, sir. Yes, sir. The presentation was exemplary, brilliant, and both the cases were really excellent. And you really stuck on with the same medicine because your knowledge in mathematica and repetition. That's the reason why you have to check it twice, whether it is right or not. And even in the second case, in the first case, you find that phosphorus comes as the best remedy after reparationalization in the second reparationalization. And in the second case, pulsatile itself came even after adding some more symptoms. That means
Yeah.
that in such conditions, and not only that, we need to wait for something. Infertility cannot
Yeah.
happen
But
all of a sudden. Occasionally, that can happen after the first preference itself, but sometimes we need for at least 6 months to 1 year minimum. But in this case, it took only nearly 6 months, I think. Anyway, congratulations, and this is the time for discussion, but only few minutes remaining. I am inviting Dr. Beatrice.
Yes, thank you very much, Dr. Danish. Thank you very much, Dr. Partha. It was a really excellent presentation. I did like it very much because it's also important subject. And for me, very interesting, especially the first case, because with all that leukorrhea, you did choose more physical remedy with borax.
yeah,
And later we
actually,
saw
yeah, yeah. Yeah, tell
all
me.
these psychological difficulties, the parents so far away. This mental situation was also very important, and you did find a very good remedy with phosphorus. Congratulations. So I also feel that the psychological surroundings are very important for the woman to conceive well.
Yeah. One question has come, what to do for low AMH? There's one question I can see over here. For low AMH, I can suggest you can think of, there's a hormonal problem. You can think of one drug, which actually I am doing in my practice, is that you can think of uforinum. Uforinum is a drug which is very good for this helping in cases of low AMH. You can try.
Yes, we need some pathological prescriptions at times, and that's the reason why that uh, second medicine came over in this second case, and that really helps. So adding a medicine to the constitutional medicine sometimes requires.
Yes.
Anyway, thank you, sir. I'm inviting Dr. Ambaresh to say a few words and a vote of thanks to the session.
Thank you, Dr. Dhanesh ji. Everyone, namaskar and congratulations, Dr. Partha Chakraborty sir. Very nice, excellent session. Infertility in female. Very good presentation. Two cases, phosphorus and pulsatilla. Young girl, pulsatilla is the suited remedy, and pulsatilla select remedy due to dipping tendency. Dipping tendency, hot patient. The cause of infertility. Cause of infertility.
Sir, time is
disorder.
sir,
Thank you, thank you. Lifestyle, general stress, obesity, malnutrition, and smoking, alcohol, etc. जो है तो बैकग्राउंड ऑफ miasmatic, sora, psychotic, and syphilitic. According to select remedy, sulfur, medoninum, sorinum.
Yeah.
So very good presentation. यहाँ पर IFPH whole team, very thanks.
Anyway,
presentation, sir. Thank you.
Anyway, 1 minute to, yes, sir. Please,
homeopathic.
1 minute to Dr. Goblim from Malaysia, because Goblim is the coordinator of IFPH in Malaysia. Okay, Bob.
I'd like to say congratulations, and it's nice to have you back here again. Dr. Professor Partha Chakraborty is a very good friend of mine and my mentor, and is very familiar with Malaysia scenario. And this is a very good session, and I'd like to say on behalf of IPH, a very big thank you to him for giving a very detailed subject on infertility and also related cases and how he solved it with homeopathic medicine. And that is a very, very good webinar for today, 2077 uninterrupted webinar. And congratulations once again. Over to you, Dr. Danesh.
Thank you. Thank you, Dr. Boblin, Dr. Ramprasad Sir, Dr. Beatrice Gessner, and our guest faculty, Dr. Partha Chakraborty, and those who attend the English session tonight. And tomorrow we will have a session from Dr. Renuka Patel, and Dr. will be talking about role of homeopathy in management of menopausal syndromes. Thank you. With that, we come to the end of the day 2077.
Thank
Thank
you.
you all. Good night.